Welcome, everyone. I'm really excited today to be part of Virtual Evolution 2021. Welcome to our lung cancer panel. I'm really grateful for the attendees and certainly all of the fantastic panelists today. And we have a very interesting case that we're going to discuss. I really encourage all the participants to type in your questions as they come to you in the chat feature, and we'll be happy to respond as quickly as we can. We'll make sure we respond to all of the associated questions as it pertains to this case. So I'm going to introduce myself. I'm Shayma Kazmi. I'm a medical oncologist with Penn Medicine, and I primarily focus on thoracic oncology. And I will hand off the mic to my partners and my co-panelists today, who will also introduce themselves.
Hi, everyone. I'm Millie Das. I am a clinical associate professor at Stanford and also chief of oncology at the VA in Palo Alto. And I'm a thoracic medical oncologist, and it's really great to be here.
Hi, everyone. My name is Keane. I'm a thoracic radiation oncologist at Massachusetts General Hospital, and I'm an assistant professor of radiation oncology at Harvard Medical School.
And hello, everyone. I am Erin Gillaspie. I am a thoracic surgeon and assistant professor at Vanderbilt University Medical Center, and my primary focus is lung cancer surgery.
Thank you. So without further ado, we'll get right into our case discussion today. We have an hour together, so we'll make the best use of our time. So this is a case of a 58-year-old non-smoking female who presents with shortness of breath and cough and is found to have a 4-centimeter left upper lobe lung mass. She has associated left hilar lymphadenopathy, a bronchoscopy, and an endoscopic bronchial ultrasound shows an adenocarcinoma for lung origin. She's clinically staged to have a T2B N1 MX or stage 2B disease. Her PET scan and MRI brain do not show any disease outside of the thorax. And she did get genomic testing sent out, and she happens to have an EGFR exon 19 deletion mutation presentation. So with that case in mind, Dr. Gillaspie, can you please take us through the surgical considerations in this case?
So surgery commonly plays a role in patients presenting with local disease and some locally advanced stages of disease also. A critical part of management is understanding that the larger the tumor or the involvement of lymph nodes, surgery alone is really insufficient in the management of these patients, thus demanding a multidisciplinary approach like bringing together all the people on this panel. So let's talk just a little bit briefly about some of the steps and how we got to the stage of this patient. So we're seeing a big transition right now with historically more invasive procedures in the performance of both staging and definitive resection. And now we're moving to much more minimally invasive approaches. And one of the first places we're really seeing this is with mediastinal staging. And so traditionally, patients were undergoing a mediastinoscopy for a formal pathologic staging of their mediastinum. And you can see here the mediastinoscopy in the upper pictures. And this served as the gold standard for 70 years. There was an incision performed on the neck. We went down along the trachea with a special scope and sampled the lymph nodes. In 2004, due to advancements in endobronchial ultrasound, bronchoscopes became newly equipped with an ultrasound that allowed for the assessment of lymph nodes within the airway. So EBUS, or endobronchial ultrasound as we call it, is really a minimally invasive mechanism that allows us to examine and sample lymph nodes. And this can be performed with a very high sensitivity, specificity, and allows for evaluation of not only the N2 and N3 nodes that we were traditionally sampling with mediastinoscopy, but also the N1 nodes. And so that allows us to get this patient to an N1 using the EBUS for helping to pathologically stage the patient. Newer and other bronchoscopic techniques have also evolved as well, including electromagnetic navigation bronchoscopy. And what this does is it actually uses the concept of virtual bronchoscopy and facilitates approaching a lung lesion for biopsy. And what this has done is it has allowed us to biopsy nodules that are more peripheral, smaller, and traditionally in difficult places to access, places that usually we'd have to do a surgical biopsy to be able to find out what the patient's histology was for their specific tumor. We've also seen more widespread use of pleuroscopy. So this is a procedure that allows for inspection of the pleural space while allowing the patient to be spontaneously breathing. And so we can inspect the pleural surfaces themselves, perform biopsies, take down adhesions, and even perform a pleurodesis. So next on to surgery. So a lot of people broadly categorize surgical procedures into kind of two major categories, minimally invasive and open, with the word VATS often being used interchangeably with minimally invasive surgery. And the reality is we really have a smorgasbord of minimally invasive approaches, each with unique applications, benefits, and limitations. So VATS, which is one of the common surgical approaches for patients with early stages and kind of smaller tumors, more locally advanced, is video-assisted thoracoscopic surgery, and really was the beginnings of an evolution in our transition to a more minimally invasive approach to thoracic diseases and in particular lung cancer. And it's performed through 3 incisions. One incision serves as a camera port, and the other 2 for insertions of instruments. We kind of achieve a triangulation with respect to the anatomy. Since its birth, VATS has demonstrated that it can be performed safely and has great patient benefits such as reduced pain, enhanced recovery postoperatively. But the adoption really until 2010 was very, very slow. And some of the reasons cited for this was concerns about oncologic outcomes, bleeding, and then of course some technical considerations, including really a lack of specialized instruments in the early years. And still some people complain nowadays that our instruments are really very rigid, long with fixed angles. And of course, we're operating on 2-dimensional screens and patients are 3-dimensional, as are all of their blood vessels. We have seen more and more adoption of VATS over the last 10 years, which is great as we've seen kind of development of new technology, better cameras, new instruments. We've also seen the emergence of a lot of variations on this technique. And an early alternative that's emerged has been a uniportal VATS, which is basically just VATS performed through a single rib space. It's almost like having a mini thoracotomy, actually. And the benefit of this approach is it really only causes pain in one area. But of course, the downside, now we're putting a lot of instruments through a small area, requiring the development of even more instruments to be able to do these procedures, which comes at a cost, of course. And we still have some of the other limitations seen with conventional VATS, so fixed instruments and 2-dimensional screens. One of the other beautiful emerging technologies that we hear a lot about and we see a lot about is robotic surgery. Early in my transition to robotic surgery during fellowship, while I was describing the surgery to one of my patients, she actually looked at me and said, "If the robot can't get this done, are you going to come in and finish the job?" And I think her statement so perfectly captures the mysticism and lore when we talk about robotics. This is a technology that allows for the performance of pulmonary resections and really has allowed a lot of surgeons to tackle more and more complex procedures, sleeve resections, segmentectomies, chest wall resections, because it's been able to overcome some of the other limitations that we've seen with minimally invasive surgery. 3D high resolution images has been one of the huge advances. We have enhanced degrees of freedom of the instruments. They replicate the movements of our hands. So it's like miniaturizing our hands and putting them in a patient's chest. Unfortunately, this technology has sacrificed haptic feedback, so we can't feel how hard we're pulling on a structure. I suppose we really can't have it all in one technology, unfortunately. And here's some pictures from a robotic surgery where you can see just our little incisions and some of the instruments that we're using to dissect out a pulmonary artery. Now, for patients who would benefit from an open approach, one of the things that I always think about is trying to use less morbid incisions. That should always be considered, such as using a muscle-sparing thoracotomy, where all the chest muscles are actually carefully identified and reflected out of the way, giving us access to the chest, again, going through one rib space, shingling in the back, you get plenty of view, and you're creating a much less morbid and much less hard recovery for the patient, which is really nice. So we're doing a lot of surgeries this way, which is really, really wonderful. People are constantly pushing the boundaries of what we can do minimally invasively. And, why is it so important? Well, really, at the end of the day, everything we're doing is for the benefit of the patient. And we've been able to show that patients can have an equal oncologic outcome. There's multiple studies showing that now. We have an improved morbidity, so fewer complications. Patients are having a shorter length of stay. And of course, less pain. And in the setting of an opioid epidemic, that is absolutely critical. At the end of the day, no matter what, though, there's some key surgical principles that we need to think about for our patients when we're doing surgery. And that includes this patient. So thoughtful patient selection, making sure that they have appropriately managed comorbid conditions, that they have adequate pulmonary function to be able to do surgery. Careful selection of order of therapy. Should they have neoadjuvant or adjuvant treatment in addition to their surgery? Completeness of resection, I cannot emphasize this enough. We need negative margins and a comprehensive lymph node staging, and of course, using minimally invasive surgery where appropriate. I just wanted to throw one quick last slide in about something called ERAS or ERATs, which you'll be hearing a lot about. A lot of programs are bringing in these protocols to help patients after surgery with recovery. And it's a comprehensive protocol that starts all the way before surgery. So actually putting them in prehabilitation programs and then moving to preoperative optimization of comorbid conditions, smoking cessation, minimization of tubes and lines. So don't put it in the patient if it's not going to benefit them. And of course, multimodal pain approaches. All things that I think highly important for the care of this patient.
Thank you, Dr. Gillaspie, for that really thorough and exciting presentation. I think surgeons are always going to fascinate me with everything that you do. So exciting, and it almost sounds like a video game, which is great. So assuming that this patient undergoes a very good surgery per Dr. Gillaspie's notation, there is no positive margins, there's complete resection. And remember, I had mentioned that this patient has an EGFR exon 19 deletion mutation. Let me take you through some of the salient points of really the practice-changing ADAURA clinical trial that we're all probably familiar with at this point. Some of the reasons why this trial was really indicated was, we know that 30% of patients have resectable disease at diagnosis. Most people don't. However, the patients who are resectable and are early stage, usually if they're advanced stage 2 to 3A, undergo 4 cycles of adjuvant cisplatin-based chemotherapy. And of course, carefully selected stage 1B disease patients can undergo the adjuvant chemotherapy as well. Now, that despite adjuvant chemotherapy, we know it improves overall survival, disease-free survival in stage 2 to 3 disease. Recurrence rates are extremely high for non-small cell lung cancer in 30 to 70% range, which is a huge room for improvement. And so with genomic testing, and we know that osimertinib has done really well in patients with advanced EGFR mutated non-small cell lung cancer. And it just makes sense to incorporate this therapy in the adjuvant setting to evaluate whether it also reduces disease-free survival and ultimately overall survival in patients with these activating mutations. So safety and efficacy was already established in late-stage disease. And so the phase 3 ADAURA trial was based exactly on this group of patients who had resectable stage 1B to 3A EGFR mutated non-small cell lung cancer. And they looked specifically at the 2 activating mutations, exon 19 deletion mutations and L858R mutations. They did not look at some of the rare mutations that we may come across in our testing, which only complicates our decision making, right? So this was the ADAURA study design. It was an international randomized double-blind phase 3 trial. And then these were patients with completely resected stage 1B2 to 3A non-small cell lung cancer. Of course, as Dr. Gillaspie said, the patient had to have had a good surgery, negative margins. These patients had to have an EGFR exon 19 deletion or L858R activating EGFR mutations. They had to be adults with a good performance status 0 to 1. They had to have brain imaging done, of course, to rule out distant metastatic disease. Adjuvant chemotherapy was absolutely permitted and was left to the discretion of the investigator. And then maximum time from surgery to randomization was about 10 weeks with adjuvant chemotherapy and 26 weeks, 10 weeks without adjuvant chemotherapy and 26 weeks without adjuvant chemotherapy. Patients were stratified 1-to-1 with osimertinib 80 milligrams once a day or placebo once a day. And the duration of treatment was 3 years. Of course, the duration would be diminished if patient had recurrence or there were other criteria met, in which case they had to leave the clinical trial. The primary endpoint was investigator-assessed disease-free survival in patients stage 2 to 3A disease. Notice the 1B was not part of this primary endpoint. The trial designed to test the superiority with the estimated hazard ratio of 0.7. The secondary endpoints was the disease-free survival in the overall population, including the early stage patients. And then, of course, at different markers at year 2, 3, 4, and 5. Overall survival was a secondary endpoint. And then, of course, quality of life and safety. So these are the baseline characteristics of the trial. I won't get into too much of it. That except that it was fairly balanced with the OC arm and the placebo arm. There were some smoking patients. A quarter of the patients did have smoking history. So remember, that's not in any way an exclusion for having your patients tested genomically for driver mutations. Most patients had good performance status. 31% in each arm had stage 1B disease, and the other 2/3 were stage 2 to 3A patients. About half had the exon 19 deletion, and the other half had the L858R mutation. And over half the patients received adjuvant chemotherapy in both arms. So this is really the Kaplan-Meier curve for disease-free survival in the primary endpoint, which is stage 2 to 3A non-small cell lung cancer patients. So as you can see, the blue line on top is osimertinib, and orange, there is a clear separation of both lines really early on, starting as early as 3 months. And as you can see, the hazard ratio is striking at 0.17, so over an 83% improvement in disease-free survival in these patients who received osimertinib versus placebo. Now, the maturity is about a third of the way in, maybe a little bit more now since this was presented, but that clearly tells us that there is a dramatic, statistically significant improvement in patients who had osimertinib. Now, when you look at the overall population, of course, you would expect that the stage 1B disease would have a less of a significant improvement. However, the hazard ratio is still 0.21 for the entire population. And again, also very early on, the curves separate. Now, when you look at the specific subgroups that may have benefited with OC versus not, there's not a specific group that that really jumps out at you that may not benefit. So really based on whether they're male or female or age or smoking status, none of that mattered. The race did not matter either. When you look at the stage 1B patients, that's probably the only group that you see approaching the midline. Of course, there were 212 patients, though it is entirely to the left of the line. You can see that the hazard ratio there is 0.5. It meets statistical significance barely. And so that's a group that I think one can comfortably argue one way or the other, whether 3 years of adjuvant osimertinib is worthwhile in those early stage patients who already have a very high chance of cure. Now, obviously with stage 2, 3A, there's no question. The type of EGFR mutation, you can see exon 19 deletion traditionally fares better. L858R is a slightly worse prognosis, though both groups benefited with adjuvant osimertinib, and whether the patients had chemotherapy or not did not seem to affect their overall benefit from osimertinib. When you break it down by stage, as this slide is doing, when you look at the stage 1B, as I mentioned, probably the benefit in this group of patients is the least compared to the higher stage patients. However, even in these early stage patients, one cannot deny the level of benefit that you see with osimertinib. Certainly we don't have overall survival data, and so 3 years of osimertinib does not come without a price. So I think that's certainly something that we need to discuss with our patients very closely. As I mentioned, this is the very early overall survival data. Of course, there's a trend to improvement, but the maturity is far away from any significant sort of interpretation of this, but we're going to be watching this closely. Now, safety. Remember, quality of life was one of the considerations with ADAURA. Certainly having no active drug for 3 years is very different from having an EGFR a targeted agent, although osimertinib was fairly well tolerated. 20% of patients had grade 3 or greater AE. That's any cause. Notice even in the placebo group was 14%. So when you look at causally related AEs, which are most specifically related to the drug, 10% of patients versus 3 had greater than grade 3 adverse reaction. So small numbers, and 3% had serious adverse reaction. So not something that would preclude us from considering this drug at all, but certainly something to keep in mind. Median duration exposure for these patients has been a couple of years. There was 1 death in the placebo arm. There was some ILD in 1 patient receiving osimertinib. We know that that is certainly a possibility with this group of drugs. And grade 1 to 3 QTc prolongation in 7% of patients. So that's something to certainly monitor in patients who may have comorbidities and cardiac disease, as well as perhaps some inherent tendency to have QT prolongation. Those patients may need to be monitored closely and really educated on the risks and benefits. This is all causality. Adverse reactions certainly be associated with this drug with diarrhea, with dermatitis, acneiform rash, paronychia. All of those AEs are fairly tolerable numbers, and grade 3, 4, really very, very small single-digit numbers with osimertinib. But certainly pruritus, cough, stomatitis, all of these are related to the drug, all low-grade and manageable. So in unplanned interim analysis, we know that osimertinib significantly prolonged disease-free survival versus placebo after complete resection in patients stage 1B through 3A. So our patient certainly qualifies given that she had stage 2B resected disease. And we can counsel this patient on the risk reduction in recurrence or death. And then disease-free survival was prolonged. There's no new safety signals specifically. We're certainly waiting on long-term overall survival data, but we really have approval for this drug at this time, and this group of patients and adjuvant osimertinib should be incorporated into the standard practice for treating these patients. Now, certainly my current practice is to continue with adjuvant chemotherapy first for these patients, then followed by adjuvant osimertinib. I know there's a lot of debate on whether that's appropriate or we can forego the adjuvant chemotherapy, though my personal practice is that we continue that as well as adding the osimertinib. So with that, we can move on to the next scenario. So we're going to take the same patient. Let's say this patient does not have an activating EGFR mutation. We sent off the genomics and there's nothing that jumps at you. The PD-L1 turns out to be 20%. So the patient appropriately undergoes 4 rounds of adjuvant platinum-based chemotherapy. And so the next question really is going to be, what about the exciting new data with checkpoint inhibitors and adjuvant setting? So I'll have Dr. Das take us through some of the new data with checkpoint inhibition in the adjuvant setting.
All right, so I did want to discuss the IMpower010 trial. This was presented at ASCO this year by Dr. Wakely, who's one of my colleagues and mentors at Stanford. So the IMpower010 study design is shown here. So this was a study that was conducted in completely resected stages 1B through 3A non-small cell lung cancer patients. Patients with 1B tumors had to have tumor size greater than or equal to 4 centimeters. Good performance status, patients had to have undergone surgical resection with either lobectomy or pneumonectomy, and they had to have tumor tissue available for PD-L1 analysis. These patients went on to receive standard of care cisplatin-based adjuvant chemotherapy for 1 to 4 cycles, and then were randomized 1-to-1 to receive either atezolizumab or best supportive care. So atezolizumab, as you may know, is a PD-L1 antibody. It was given at a dose of 1,200 milligrams IV every 3 weeks for 16 cycles. The primary endpoints here were basically, it was investigator-assessed disease-free survival that was tested hierarchically. So specifically in the PD-L1 positive patient population. So these are patients looking specifically at PD-L1 greater than or equal to 1% in the stage 2 to 3A population, in the all randomized stage 2 to 3A population, and then also finally in the intention to treat population, which includes those patients with stage 1B disease. Okay, and so these were the results that were shown. This is the disease-free survival in the PD-L1 positive stage 2 to 3A patient population, which is the primary endpoint. Here you see that patients who received the atezolizumab did better compared to placebo with a hazard ratio of 0.66, which is statistically significant. Looking here now at the forest plots and broken down by subgroups, you're seeing really all the patients benefited with the atezolizumab compared to best supportive care, regardless of age or gender, race, histology. Where you're seeing a little bit of crossover here is the ALK rearrangements, but really we're seeing benefit with the atezolizumab across subgroups compared to best supportive care. Disease-free survival in the all randomized stage 2 to 3A patient population. So this also included those patients with who were PD-L1 negative. Again, you're seeing patients who received the atezolizumab doing better compared to the best supportive care arm. Hazard ratio is 0.79, p-value of 0.02. when you look really specifically at the PD-L1 status in the stage 2 to 3A patient population, those patients with higher PD-L1 expression seem to derive more benefit from the atezolizumab. So the high expressors of greater than or equal to 50%, really the highest benefit with a hazard ratio of 0.43. When you're using a PD-L1 cutoff of greater than or equal to 1%, continue to see benefit in those patients receiving atezolizumab with a hazard ratio of 0.66. And the PD-L1 negative subgroup, these are the patients that don't seem to be deriving the same benefit. And here the hazard ratio is close to 1. Looking at disease-free survival and the intention to treat population, which includes those patients with stage 1B disease, you can see here that this disease-free survival here did not cross the significance boundary at this interim DFS analysis. I really think it's a little bit too early to provide overall survival data. And so they did give us a glimpse at some of the early overall survival data at this interim DFS analysis. You can see maybe a trend toward overall survival improvement with atezolizumab seen in those patients with PD-L1 expression of greater than or equal to 1%, but can't make a whole lot of this at this interim analysis. So my overall conclusions from this study is that this was the first phase 3 trial of adjuvant immunotherapy to report results. And this study did show that atezolizumab improves disease-free survival in a hierarchical analysis for PD-L1 positive resected stages 2 and to 3A non-small cell lung cancer patients, and in all stage 2 and 3A patients. Overall survival data, of course, remains immature. I didn't go through the adverse events with you, but they were mostly immune mediated and as expected, consistent with prior immunotherapy trials. And so the big question is, are we going to see an FDA approval in this space? And of course, we don't yet have an FDA approval. When we think about this particular patient case, she has a PD-L1 expression of 20%. So this is a patient that I think would potentially benefit from atezolizumab. Would I be offering it to this patient at this time? Probably not. I think in the absence of an FDA approval, it's going to be really tough to get a payer to approve this drug. I do think we will likely see an approval for this drug. And then the big question is it going to be limited to patients who have PD-L1 positivity? So I think stay tuned. And I do think this is a really exciting abstract and maybe practice changing.
That is great. Thank you so much, Dr. Das. But yeah, so many questions remain. We want our answers relatively quick, and we don't necessarily have that. So of course, the harder question is if our patient really did have the EGFR mutation and had a PD-L expression of 20%, given that some of these patients had that, in which order would you treat? Would you treat with the OC? Would you give atezo? I know there's, of course, the interactions between TKIs and IOs and higher risk of immune-mediated AEs. So there's so much to consider, but I think it's a really exciting time. So again, feel free to ask your questions on the chat function. We're gonna mix it up a little bit more and change the case even more so. Now let's assume that this patient has more advanced disease, as we typically see. This patient has unresectable disease, bulky nodal disease, N2, N3. They were biopsied, but certainly don't qualify for surgical resection. Their PD-L1 test says 0, and there's no EGFR mutation. So this would be a great time, again, Dr. Das, if you could give us a little bit of insight into the updates of the Pacific trial, which of course was practice changing a little while ago. So I will hand it over to you again.
Great, thank you. So here is the Pacific trial, which many of you are probably already familiar with, because this was a practice-changing trial. This was a phase 3 randomized, double-blind, placebo-controlled, multi-center international trial. It involved unresectable stage 3 non-small cell lung cancer patients. And so this patient really falls into that category now with bulky N2, N3 disease. So assuming these patients did not develop disease progression after definitive platinum-based chemoradiation, maintained good performance status, they went on to get randomized within 1 to 42 days after chemoradiation to either durvalumab or placebo. So durvalumab is a PD-L1 antibody. It was given in this trial at a dose of 10 mg per kg IV every 2 weeks for up to 12 months. Primary endpoints were progression-free survival and overall survival. And this is the data that was presented at ASCO this year, which is the 5-year update. which is showing us continued benefit with durvalumab at 5 years compared to placebo. So the 5-year overall survival hazard ratio is 0.72, which is statistically significant. So my conclusions from this is just that we're seeing a robust and sustained both progression-free and overall survival benefit in these patients receiving durvalumab at 5 years. We know that this trial, again, has been practice changing, and we're offering our patients durvalumab after completion of definitive concurrent chemoradiation, and we're continuing to see benefit at the 5-year mark. Really, I think it represents unprecedented survival being seen at 5 years, with greater than 40% of our patients remaining alive and a third of these patients without disease. We know that these patients with stage 3 disease are at a very high risk of recurrence and death from recurrence. And so I just think that this 5-year data really just reinforces the benefit of durvalumab in our patients with unresectable stage 3 disease. I think the question, though, is now, do all patients benefit with durvalumab? And I think this has been called into question, specifically looking at the EGFR mutant patient subsets. Are these patients benefiting from durvalumab? There's some concern that they may not be. And in fact, if you're treating these patients with durvalumab and they develop disease progression, there's a bit of an issue with starting an osimertinib at the time of disease progression if they've been on durvalumab, given the increased risk of pneumonitis. And so in my clinical practice, I tend not to give durvalumab to my EGFR patients. There's also been some subset analyses of the Pacific trial looking at patients who did not have PD-L1 expression, as is the case for this particular patient who had a PD-L1 of 0. Some of these subset analyses have indicated maybe less benefit with the durvalumab given as consolidation treatment. And so I think, again, there's a lot of interest in still trying to tease out which patient subgroups are most likely to benefit with the durvalumab. The approval for durvalumab is really for all patients, regardless of PD-L1 expression. So I would certainly offer the patient durvalumab, thinking probably in the back of my head that maybe this patient may not be deriving the same benefit as a PD-L1 positive patient.
That's great. I absolutely saw one of those patients today, in fact, in clinic, and unfortunately he had durvalumab for a year, and this is a year post his completion, and he has recurrent disease and PD-L0 patient. So yes, absolutely. It was always in the back of my mind that the benefit is going to be muted in this group of patients. So thank you for that thorough review. I'm going to ask Dr. Keane now to take us through some of the considerations for radiation, at least in this particular patient for chemoradiation.
So what is the role of radiation in the management of patients with locally advanced non-small cell lung cancer? We know radiation plays a role in patients with multiple different stages of lung cancer. Obviously, for this patient, we're focusing on someone with unresectable disease who's not a candidate for surgical resection. So they would be in this bottom cohort of either bulky or fixed N2 or N3 nodes, where due to the extent of nodal disease, the main role of treatment is with chemotherapy and radiation rather than resection. So in general, for definitive chemoradiation patients here, there's patients obviously who are not candidates for surgery, as I mentioned. We also consider chemoradiation for patients who might not be candidates for surgical resection. The main question, though, historically has been, what dose of radiation should you deliver? And to answer this question, RTOG 0617 was conducted. This was a randomized trial that was a 2x2 design, attempting to answer 2 questions simultaneously. They randomized over 400 patients with unresectable stage 3A or 3B non-small cell lung cancer to either receive concurrent chemoradiotherapy. All patients received carbotaxol, and the radiation dose was either 60 gray in 2 gray fractions or 74 gray in 2 gray fractions. This was delivered with or without cetuximab. Patients following completion of chemoradiation would receive consolidative chemotherapy, since this was obviously designed prior to the publication and completed prior to the publication of the Pacific trial. And the results were very surprising to everyone who expected that more radiation dose would be better. As you can see on the chart here, the blue line, which is very clearly separated from the red line, is in fact the 60 gray, so the control arm. And so the curve split around 3 months and remains split with really a widening of the curve even out to the year and 3 month mark. As you can see on the table on the right, outcomes were in general better in the lower dose arm for almost all metrics. Median survival was 29 months versus 20 months. The 2-year overall survival was significantly different. There was also, interestingly, a difference in local failure between the 2 arms, which was very challenging to understand. And this all translated to obviously prolonged differences in overall and progression-free survival. The study closed early due to futility. And when we looked at these answers, the question obviously becomes, well, why does this higher radiation dose lead to counterintuitively worse survival and a trend towards worse local control? And we're left with a few answers. I think one thing that has become abundantly clear over time, as Dr. Gillaspie talked about the advances in surgery, there have also been several advances in radiation technique. And when we're delivering definitive courses of radiotherapy, particularly at these high doses, we know that it's critical to not just treat the tumor and normal structures, but we always have to be very cognizant of the dose received by the normal structures nearby. For example, you get an idea as to how some radiation plans are delivered. The center area here is your gross tumor volume. And then on most of these studies, a CTV is put on for microscopic tumor control, followed by a PTV, which is for setup each day. And on several trials, the entire dose of radiation is delivered to this entire volume. So the gross disease and the microscopic disease gets the same dose. And obviously, as you can see here on this slide, this results in a significant portion of the esophagus, nearly 75% of it, in fact, receiving the prescription dose. By contrast, with improvements in technology and imaging, there's been some arguments to shift towards a shrinking fields technique where you give a dose designed to cover the microscopic disease and then shrink your fields to focus on the gross disease. And as you can see here, this results in significantly better sparing of the esophagus. The other thing that's critical to note is how little was known about normal tissue tolerances and how much more has been known. On the RTOG 617 study, there were very few constraints in terms of dose design. So the mean dose to the esophagus was kept below 34 gray. And for the radiation oncologists who are on, it's very challenging to ever exceed that. So that's a very generous constraint. And the heart constraints were also quite generous. So the entire heart could receive 40 gray, 2/3 could receive 45 gray, and 1/3 could receive 60 gray. And when they looked at the results of 0617, they found that in fact, these toxicities were contributing significantly to the worst outcomes. So the size of the PTV, treating these very large fields, and also the dose to the heart were independent predictors of overall survival. The heart V5 reflects the volume of heart that's receiving 5 gray. So that's a very low dose that normally you would think would be somewhat discounted, but it was actually critical in terms of impacting patient outcomes, as was the heart V30. The heart V50, so the volume receiving 50 gray, has also been shown to be a critical impact on survival. Now we know that using advanced radiation techniques is much better at sparing the heart and other normal organs. And IMRT is a critical element when we're considering this. This is a slide that goes over some of the work that's been done on parsing out cardiac tolerance to radiation and cardiac toxicity. These are 3 different publications. The first one was a post hoc analysis of 6 prospective trials. The second is also a post hoc analysis of 4 prospective trials. And the third column, Atkins et al., is a retrospective analysis. These were all patients with advanced lung cancer, and they all received, importantly, definitive doses of radiation. So most of the patients on the JCO study were receiving at least 70 gray, similar to the study by Dess et al. And the study with Atkins et al. Was also definitive doses of radiation. In this study, most patients were receiving 3D conformal radiation, as was the case in both of these studies, as the majority of patients were treated prior to the widespread use of IMRT. Cardiac dose limits were incredibly generous, so the heart was able to receive high doses of radiation. I should make note that no radiation oncologist sets out to deliver a high dose of radiation to the heart, but often when you have bulky tumor volume, particularly like a large subcarinal lymph node, it's very challenging to avoid the heart. And these constraints reflected the challenges of treating patients in the 3D era. When they looked at the events, there were a significant amount of cardiac events and cardiac disease outcomes in these studies, and it correlated directly with the dose received to the heart. Over nearly a quarter of patients had at least one cardiac event, and these cardiac events actually happened relatively quickly. So a median of 26 months. In the second study, 15% had cardiac events at 11 months. And so it's an important thing to consider because historically these toxicities were thought to not manifest till years later, and clearly they're happening very quickly and impacting patient outcomes just as much as their cancer is in many cases. It also holds true, as we see in the study from Atkins et al., for patients who did not have cardiac disease. So this is not just a reflection of patients having significant coronary artery disease or atrial fibrillation or other comorbidities prior to treatment. And so when we take these into account, we are left with these two curves being split, and knowing that 74 gray delivered with 3D conformal radiation is just not a safe or tolerable technique to give. And what is really critical, and I think the take-home message from this study and the subsequent work has been done, is how important it is to use modern radiation techniques to minimize toxicity while maximizing dose. Intensity modulated radiation is associated with both reduced toxicity and improved patient quality of life. Those patients treated with IMRT on RTOGO617, the dose escalation study I mentioned, had improved metric outcomes, including quality of life. And at our own experience, we have seen much lower rates of pneumonitis and esophagitis. Just to give you some pictures and examples of what IMRT can do. So on the top right, this is the collimator, and so you have multiple leaves that are used to shape the dose. The radiation can be delivered from multiple angles, or it can be delivered in a circumferential arc, as you see here. And what this enables us to do is treat tumors while carving away from structures we want to avoid. This patient has very calcified coronary arteries, as you can see here, and we're able to carve the low dose around this artery while still maximizing dose to a very large subcarinal lymph node and left hilar lymphadenopathy. Similarly, with the esophagus, we're able to carve around the esophagus, and work done here was published last year in JAMA Oncology in a phase 1 trial showing significant improvement in patient outcomes with a technique that basically uses this advanced technology to make sure that we're adequately treating the tumor while protecting these organs. And I think those will be the critical continued advancements when we think about radiation going forward, particularly in these patients who we know are going to get adjuvant therapies like durvalumab and maybe someday targeted therapies.
Thank you, Dr. Keane. This was very thorough and certainly very enlightening. To that end, we're going to have a little twist on the case. Assume this patient had, really good initial surgery, appropriate adjuvant therapy. Patient completed osimertinib for 3 years. Unfortunately, despite all of that, develops a right lung metastases, solitary, 2.5 centimeters, no other distant disease, and was restaged with MRI brain that was negative. So I think we're now dealing with an oligometastatic disease, and we want to give you, Dr. Keane, another opportunity to give us a little bit more information on how we use radiation in this situation.
Thank you, Dr. Kazmi. So this is a very exciting area in oncology in general, and this is the role of the area where we're considering using aggressive local therapies in the treatment of patients with metastatic disease. And radiation has played a significant role in this area. Surgery also plays a role, but for the purposes of today, we're going to focus on radiation. And I like to group the role of radiation in these cases into 3 categories. You have patients with oligoprogression, and so these are patients with isolated sites of progression but are on otherwise effective systemic therapy. You have patients with oligometastatic disease, which is what our patient has. And this is an area where we think that delivering aggressive local therapy in patients with few metastases can lead to improved outcomes. And the final area is synergy with immunotherapy. So the technique of radiation that is typically used when we're thinking about radiation for oligometastatic disease is stereotactic radiosurgery or stereotactic radiotherapy. The other term for it is sometimes called SABR, so stereotactic ablative radiation. But the common thread is that this is high dose radiation that is delivered over a short course and has an ablative effect on tumors. What this technique allows us to do is by delivering radiation from multiple angles, we can deliver a very high dose of radiation very conformally, so in a safe manner, to effectively treat a tumor while sparing adjacent normal areas. For example, in this instance, we are treating a vertebral body metastasis with the dose in red, boosting an area of gross disease in purple, but carving out a hole around the spinal cord. Now, what is oligometastatic disease? This has traditionally been an area of debate. Historically, this was defined as solitary brain or adrenal metastasis in a patient with a T1 to T2 and 0 lung cancer. In other words, disease that can all be fully resected. The definition has broadened in past years with improvements in systemic therapy, as well as improvements in local treatment techniques. A multidisciplinary consensus group published recommendations in JTO suggesting a maximum of 5 metastases and 3 organs to consider someone to oligometastatic disease. But there's certainly a lot of variation between groups as to what the true definition is. And randomized trials have really allowed patients with a range of metastatic sites. These are some examples of 3 different studies of radiation in oligometastatic disease. The first 2 were exclusively in patients with non-small cell lung cancer. SABR Comet included approximately 18% of patients with lung cancer. In terms of the studies, as you can see, there is a variation in the number of metastases patients could have, up to 3 with Gomez et al., up to 6 with Iyengar et al., and up to 5 in SABR Comet. The consolidative local therapies could be radiation or surgery, as would be expected in a patient where you're treating every visible site of disease. There was an improvement in progression-free survival, which you would hope for. But what is interesting is that this did seem to translate into a reduction in the time to new, in an extension in the time to new lesions, and also an improvement in overall survival, which is really the critical metric when we're considering these outcomes. Now, there's certainly more data that's needed in this area. I will note that on these trials, although ostensibly patients could have up to 6 metastases, in general, 2/3 to 75% of patients enrolled had 1 to 2 metastases. So I would say the role of radiation in oligometastatic disease, for example, for someone with 6 different sites is really an area that is still under study. In patients with oncogenic driver mutations, there's been particular interest in that these are patients who have very effective systemic therapies, and so are living a long time. And for these patients, we do have increasing data that treating an isolated site of progression can improve their outcomes by allowing them to remain on an otherwise very effective systemic therapy. And we also know that patients with these driver mutations can often fail in their primary site. And so that has led to interest in whether we can preemptively consolidate or treat them with radiation to use another tool before they have the time to progress and develop additional metastases. This was a randomized trial that looked at this question in EGFR patients. So all patients were on an EGFR TKI, and they were randomized to receive SBRT or not. And there was an improvement in the primary endpoint of progression-free survival between these 2 arms. So when we consider consolidative radiation in patients with metastatic lung cancer, I think it's really important whenever possible that we enroll patients on randomized trials. NRG has an ongoing study that's looking specifically in patients with lung cancer. And I think this is really a critical question, especially when we think about patients with a really extensive burden of 3, 4, 5, 7, 8 metastases, who is the appropriate candidate? Because we do know that even though these radiation techniques are very conformal and in general safe, they can have toxicities. The other area that I will just touch on briefly is the potential synergy of radiation with immunotherapy. And specifically, I'd like to mention this phase 2 study that was a randomized controlled trial of patients who had progressed on first-line systemic therapy and then were randomized to SBRT followed by pembrolizumab versus pembrolizumab alone. The dose of radiation was relatively low, Acre ×3, so not the ablative dose that we typically think of. And patients either received SBRT followed by Pembro, or they just received pembrolizumab. Now, there are caveats with this study, namely that patients were not stratified by PD-L1 status, which we know is important, and therefore there were more patients with increased PD-L1 expression in the SBRT arm. What was particularly interesting, though, was that in the cohort of patients who had PD-L1 0%, there was a significant improvement in outcomes in those patients receiving SBRT, suggesting that potentially radiation can function to stimulate an immunologically cold tumor, if you will, to respond to radiation. Safety is really a critical consideration whenever we're considering SBRT. We have data from the Pacific trial. We know that treating larger doses with radiation with patients who are on concurrent treatments like immunotherapy or TKIs can be fraught. And so our personal practice, for example, is if we're delivering radiation to a lung metastasis in a person who, say, has EGFR and is on osimertinib, we will hold the TKI on the days of radiation just to try to minimize potential for overlapping toxicities, which is particularly important to consider. And so when we're thinking about these patients, we know that we have increased data for the use of local therapies. And I think above all, patient selection is critical. And this is where having a great multidisciplinary community comes in, so we can ensure that patients are receiving the best potential combination of therapies for their diagnosis.
Thank you so much, Dr. Keane. We cannot end any lung cancer case without giving adequate discussion and respect to lung cancer screening. As we know, we really utilize this tool really poorly across the United States, and really we could do better in terms of screening the patients who qualify. There have been some recent changes and updates on lung cancer screening guidelines, and Dr. Gillaspie will take us through some of these.
Yeah, absolutely. Thank you. And Dr. Keane, I couldn't agree more with some of your comments. These cases are all so challenging and just demand a multidisciplinary approach to make sure we're doing all the right things for our patients. So as you've probably heard us say, a number of times today, is that the majority of patients are presenting with later stages of disease. And while we have this just really extraordinary and dramatic expansion in our treatment options for these later stages of disease, we'd still really ideally like to identify all patients at the earliest possible stage. And that's because we know that survival is enhanced by an earlier stage at diagnosis. Screening tests are created with a few goals in mind. So the first, of course, is what we just talked about. So detecting a cancer prior to the presentation of symptoms in an early stage, which enhances our treatability. Early efforts at developing lung cancer screening were really focused on using things like chest x-rays, sputum sampling, and they were really mostly unsuccessful and had no change in the rate of lung cancer deaths. However, we start to see technological advancement, which is kind of a theme of what we're talking about today. And in particular, with the advent of a low-dose CT scan, this is now a new and attractive option to consider for lung cancer screening. And really, the landmark trial evaluating the use of a low-dose CT scan is our National Lung Screening Trial, so the NLST. And this is a multi-center randomized controlled trial performed in the United States that compared an annual chest x-ray to a low-dose CT scan in 53,454 patients who were considered high risk for lung cancer. And actually, the study was terminated early when it met its primary endpoint of achieving a 20% relative reduction in lung cancer mortality, favoring that low-dose CT arm. And I think some of the big key take-home messages from this trial are a few things that I'll go over with you here. And so one, again, we've achieved a 20% relative reduction in lung cancer mortality in patients who are high risk undergoing low-dose CT scan. Nearly twice as many cancers were detected in early stage compared with the chest x-ray group. And importantly, it's actually a really good study and compares favorably to the other types of screening tools that we have. So 320 patients must be screened to prevent one lung cancer death, which compares really nicely to the 1,339 that we have to screen to save one life from breast cancer. Additional trials have been performed but really only 2 were adequately sized to detect a difference in lung cancer mortality. And so, of course, we have the NLST, which we talked about a little bit, and then more recently, the Danish-Belgium lung cancer screening trial, or the Nelson. And this actually reconfirmed the results of the NLST. And in fact, they detected 26% relative reduction in lung cancer mortality when screening high-risk individuals with a low-dose CT scan compared with no screening. So again, further supporting the role of lung cancer screening in high-risk individuals. So how do we apply screening? Well, really it requires a dedicated team. And so we need radiologists, clinicians, and this could be a pulmonologist, medical oncologist. It can be internal medicine doctors, coordinators who are going to help to organize the scans, communicate the results, and of course, coordinate additional testing. Because unfortunately, the reality is about 25% of people will have some kind of a finding on their scan that's going to require additional imaging or a procedure to help determine if those findings are benign or malignant. Now, a lot of people ask, what are the risks associated with screening? Well, of course, the most common criticism is the false positives. We're going to find stuff. If we scan people, we're going to find stuff. So, but the reality is, finding a nodule doesn't necessarily guarantee that it's cancer, but it requires having a really good team who can monitor appropriately, send for additional testing, biopsies, things like that. Of course, there's also a risk of a false negative, meaning a cancer can be missed. However, as we've had the development of this lung cancer screening, our low-dose CT scan, we've seen the concomitant development of lung RADS, which is a consensus guidelines that's been designed to standardize reporting and provide management recommendations based on finding. And it's been created in all sorts of different radiology fields, including lung CT scans. And while I'm not going to go over the details of these, I just have to give so much credit to the American College of Radiology for creating this beautifully structured reporting system that has really facilitated a decrease in the false positive rates by creating this very sophisticated evaluation and reporting system that's now gone through several iterations to enhance the standardization of screening reporting and offer clear management recommendations to facilitate outcome monitoring. So now you've heard me say high risk, high risk, high risk, but who are these patients? Well, it's actually changed recently. So historically, our high risk group of patients was actually patients 55 to 80, but our USPSTF, based on accumulating data, has actually just come out and recommended that we start to expand our screening guidelines that include patients now 50 to 80 years. It used to be that we were screening patients with at least a 30-pack year history of smoking. We've also decreased that. So now patients with a 20-pack year smoking history are eligible for screening. So that's 1 pack a day for 20 years or 2 packs a day for 10 years. Now, these patients importantly should have no symptoms of lung cancer, and of course should be current or former smokers who haven't quit within the last 15 years. Now, as Dr. Kazmi mentioned, one of the big critical problems is that we don't have enough people doing these screenings. And so one of the things that I always recommend is think about screening often, and screen everyone in front of you. If you have a spouse in the room and you're treating the husband or the wife, make sure to ask them questions as well, because they often have the same risk factors and the same exposures. So take advantage of every opportunity you have to screen and to refer.
Thank you so much, Dr. Gillaspie. And you're absolutely right, though, really the docs who are screening are not amongst us, right? So our panelists are only privy to the patients who actually have lung cancer most of the time. And it really is an important educational piece for our primary care providers, physicians, really patients themselves, so I agree. I think that's a great way to sort of end today's panel. I'm going to thank everyone, especially the attendees and our Total Health Conferencing colleagues who really do a lot of work to put this together. And Dr. Das, Dr. Keane, Dr. Gillaspie, I would love for you to just have some final words to close out the panel.
Okay, so yes, I mean, it was really a pleasure to be able to be a part of this case presentation with these wonderful female colleagues throughout the country. And I think one of the main takeaways that I got from this case is just, I think, that focus on multidisciplinary care and talking to one another when we're seeing a patient and we're trying to decide what is the best treatment option for that patient. We're no longer really working within silos. We are really interdependent and, picking up the phone or bringing the case up at tumor board. I mean, there's multiple options now. And I think we all should continue to take advantage of that and really work together as teams to come up with best treatment guidelines for our patients.
Thank you, Dr. Kazmi. I would echo what Dr. Das said. This has been great to participate in. And I think, we're in an exciting time in lung cancer where there's so many advancements. And I think, by working together, we can ensure that patients are getting the appropriate combination of therapies to hopefully improve their outcomes.
Thanks to everyone for such a great panel. It's always such a joy to join all of you. I think, the big take home point for me as a surgeon is we have all of these extraordinary technologies coming out, but the key thing is we have to be applying them appropriately. And at the end of the day, what matters most for our patients is that they're getting a great oncologic outcome. So for surgery, that is negative margins and a comprehensive lymphadenectomy, no matter what incision we choose. And of course, screen.
Thank you.